We'll go on to the next speaker, who is my dear friend Dr. GAURAV LUTHRA from Dehradun. He is a prolific cataract and refractive surgeon, and he was also associated with evaluating the Hill RBF formula, and he has a lot of experience in refractive cataract surgery, and it is my pleasure to invite him to give his talk on different IOL formulas, what to choose when, for what type of a case. So over to you, Dr. GAURAV.
Hello. Yeah. Thank you so much, Ganesh, for inviting me to this amazing course, and it's always a privilege to be there, and very good afternoon, everyone. And going ahead with the topic, which is actually a huge one. We've come a long way, and starting from the first generation formulas, which some of us had the privilege of using, and then going on to the second generation formulas, the Holiday and the SRKs, which we probably used in our college times, and then of course going along to the SRKTs and the Holiday ones, which became popular, and then the fourth generation. So there's been a huge evolution, and today we are at a benchmark situation where we can actually say with almost great certainty that 90% of our patients will be plus minus half diopters of what we are aiming for, and these are the formulas on the right, extreme right, which have allowed us to reach that level of accuracy, of course, with the help of optical biometry, because measurements were the benchmark, were the cornerstone of all these formulas. So as you can see here now, when we started off, we used to have formulas which would either be, like the Hoffer Q, which was great for short eyes, and then for the long eyes with the Wong-Kok adjustment, we could use the SRKT. So they all had their own plus and minus points. But today, if we look at the bottom of this table, the Barrett's 2 and the Hill RBF, they seem to have the best range for the short as well as the very long eyes, and both of them do extremely well. So these are the two formulas which, if you are looking for just a one size fits all for 95% of your patients, these would be the two formulas, which with the new version of the Hill RBF as well, which can go up to the minus meniscus lenses as well. Both of them are extremely good. So starting from the SRKT, which is a theoretical formula and which we have been using for long, it still holds true, because when I have to do a manual biometry in the mature cataracts, I would still go back to the SRKT. So SRKT strengths are basically for long eyes as well, and using the Wong-Kok adjustment as well, it can become a very useful formula, and should be preferred for not only the standard eyes but also for the longer eyes, especially if you are doing an ultrasonic biometry. However, the SRK 1 and 2 should no longer be used because they are obsolete and they no longer are justifiable. The Hoffer Q has been a favorite for pediatric cataract surgeons and for short eyes because it relies on a personalized A constant, and also for the axial length and the corneal curvatures. And it was and is the preferred formula. Even today, while we might measure the short eyes with the Barrett's and the Hill RBF, we don't miss out on the Hoffer Q as well, because it adds a lot to the information and can be a very useful formula for the very short eyes as well. The Holiday 2 and the Holiday IOL Consultant, which were very popular, and still Holiday 2 remains on some of the machines as a very popular formula, is again a very versatile formula from the short to the long eyes. And again, the Wong-Kok adjustment has been shown to extend the usage from the short normal eyes to the short long eyes for the minus lenses as well, and can be still used, but nobody knows about how it works. The Jack Holiday has kept it confidential, just like the Barrett's formula. Nobody knows the algorithm that is used. The Olsen C came in with a lot of promise. It's a ray tracing formula and uses the C constant. I don't use it personally. It has been popular with some surgeons. I tried to use it a few years back, wasn't so satisfied, but it is still one of the popular formulas. And I did work with Warren Hill in validating the Hill RBF from the Indian data point, and it does not depend on the ELP, so that's the advantage, and it's an artificial intelligence formula. The 2018 update and now the recent update to the Hill RBF 3 has made it a dramatically better range, because now you have the short and the long eyes from the 40 diopters to the -5, and the whole database has been increased, so the predictability has increased drastically, especially in the shorter axial lens. So now you will see much more versatility of the Hill RBF for short eyes. And now you see very few out-of-bound eyes, basically eyes where the artificial intelligence will not be able to predict it correctly. And you can also now aim for residual errors, which was not possible before. Previously, you could only aim for emmetropia. Now you can actually set, for example, if you're aiming for a minus 0.25 or a minus 0.5 or something else, you can actually feed it into the formula and it will work. And it does come with its own toric calculator, which is almost similar to the Barrett. So there's hardly anything to choose between the two toric calculators. Now coming to something which most of us tend to use today, 90% of us might be with this, especially for us who are doing optical biometry, because the Barrett suite has takes into account the posterior surface of the cornea, which is included either by measuring it or by using the nomogram for the posterior case derived from the anterior case. So Barrett's universal 2 for all non-toric IOLs is the benchmark. And then the Barrett's toric calculator, which is really popular, and I use that for all my toric lenses. And the Barrett's True-K for all the non-toric, especially in post-refractive surgery patients, is again my go-to formula for post-refractive surgery. Dr. Sheetal will be talking on that soon. So here the important thing is that for the posterior surface in the Barrett suite, when you're not using the Barrett total K, or the Barrett's TK, which Shreyas was talking about, you are not using the measured posterior surface, but a nomogram, which is proprietary and has been very useful for 90% of the cases. So the Barrett's universal 2 being a Vergence-based formula, and it does use a lens factor and a design factor. So let's see how it works. It works for all types of eyes, from the short to the normal or the long, and that's why I said it's one of the go-to formulas if you want peace of mind of using one formula for most of your surgeries. So what's necessary is the axial length and the keratometry and the lens factor, which is derived from the SRKT, and the optional factors are the AC depth and the wide to wide, the lens thickness, and the design factor. Now design factor is again, let's see how it is derived. So the lens factor is basically calculated out of the SRKT constants, and the design factor is IOL specific. So it also influences the IOL calculation. So you could actually do a calculation without the design factor, but it won't be as accurate. So to add accuracy to it, and that's why it becomes important to be measuring all those optional things which I was showing you on the right column, if you want to really make the Barrett suite work for you really well and get you more accuracy than you might get with just the axial length and the corneal measurements. So without the wide to wide, the AC depth and the lens thickness calculation, as I said, it's possible to calculate, but it won't be as precise. So the whole advantage of using the Barretts would be lost. Now the toric calculator, again, when it came out, it was amazing, and we suddenly all our concepts were changed when Barrett's toric calculator came out and was integrated into many of the machines, because it incorporates a mathematical model to calculate the posterior corneal astigmatism based on the anterior keratometry measurements. And of course, with the new IOL Master 700, you can measure the total K as well, where you can measure the posterior cornea in post-refractive surgery. I'll just come to that. So the Barrett's True-K, which we use for post-refractive surgery, I think Sheetal will be talking on it, so I'll probably bypass this, and she'll probably be talking on the ASCRS calculator as well, so I will allow her to speak. All I would like to say is that when I do my post-refractive surgery patients, I like to add as much data on the ASCRS calculator as I can. I try to put in the pentacam values, I try to put in the topography values from the optical biometer and from the OCT. Now what that does is that when you have all that data fed in, after choosing what kind of eye you're operating on, you will get predictions on, using no prior data, and if you have some prior data, then you will get it on this side as well. So frankly, you will get several of these measurements, and then I tend to usually choose the one which goes to the higher side. Of course, you have to kind of sometimes see the pentacam can sometimes be horribly wrong, but sometimes it really works well, especially in RKIs, where I use the pentacam measurements for the EK65. So this is how the pentacam holiday EKR report looks. So this has been really useful for some eyes where the keratometries are below 30, very flat corneas which cannot be measured by most of the optical biometers, and there you can use the EKR65 values starting from the 1 millimeter zone going out to the 4.5 for predictability of astigmatism if you want to do toric calculations, and for the keratometries, and this works very well for those eyes which cannot be measured by almost any device. So this is something which I really trust now. And of course, now coming to the total K, I think Shreyas spoke on this, but it is integrated into the IOL Master 700, and I will, it can be used mostly for post-refractive surgery eyes. There has been mixed opinion about how good it is. Some people find it amazingly useful, and others feel that, it doesn't add so much to the values, but maybe we can have that more in the discussion, Ganesh, on this. You have more experience. I don't use it, so. Yeah. And going on to the ultrasonic biometry, as I said, you have to, of course, have the A constant, and I use the SRKT there. And immersion is obviously necessary when you have opaque cataracts. 90% or more can be measured now with the swept source OCTs. So very few patients where you will not get a measurement even with very opaque cataracts. But when you just cannot, then you have to go by your manuals. And then, of course, it's very important to compare this data with the fellow eye. I always like to compare my manual measurements for the fellow eye. If you have discrepancy between the two eyes, you can immediately be alerted, and you can kind of go back and look at it, and look at it again, especially with posterior staphylomas and all, where you might go wrong with these eyes. So I think most of us know about all the variables which are required for the various formulas. Some are optional, some are mandatory, and I think it won't make much because we are not using most of these formulas now. You're only using the two on the right. So I think these are the ones which currently matter, and most of them will use all these variables, and that's what makes these IOL formulas more accurate. Now, some of the new formulas which can be used, the super LADAs, which has been again an artificial intelligence based formula, and can be used. It's available for free on, I think, IOLcalc.com. And this was what is popularized by Uday Devgan. Then the Kane formula, which holds a lot of promise and compares really well in most of the new studies, and has been used, for good post-op outcomes. And then the EVO formula, which is out of Singapore, and again very promising as it appears. And then the ray tracing, which is now available on some of the new machines like the Antirion, and many machines now offer the option of taking their measurements and using ray tracing calculations for eyes, especially post-refractive surgery eyes, where it will be really useful. Can't go into the details of these formulas, these ray tracing formulas, but they can be used with the Oculix software, which is again available free of cost, and can be installed onto any PC once you enter all the data from one of few of the machines which can gather all that data for it. So a lot of applications, especially in post-refractive surgery, post-RK, where otherwise you may not be able to get great measurements. So these are all the devices which can be used for ray tracing calculations: the Pentacam, the Galili, the iTrace, the Tomy, the MS39. They can all be used for, all these data can be put into the Oculix and used for your calculations. So I think I still have a little bit of time, or have I exceeded it already? Yeah, I have. Right? So I'll just summarize. I think we spoke about the short eyes. We can use the Barrett's, the Hill RBF, and the Hoffer Q. For the long eyes, this is the comparison of all the formulas for the short eyes, the long eyes, where again now things have got better and we can actually get great outcomes with some of the newer formulas, the Barrett's basically, and the SRKT when required. And I'll just finish with the last 1 or 2 slides. So post-corneal transplantation is a full thing in itself. I would prefer to do a secondary implantation if you're looking for to avoid surprises. And keratoconic eyes, you have to be very prepared for hyperopic surprises because it wrongly estimates the ELP. So the go-to formulas would be the SRKT, the Haigis, or the Hoffer Q. So to summarize, the SRKT formula is recommended for the rather long eyes, whereas the Hoffer Q is recommended. This is what we've always done. And currently, I think the 4th generation formulas, which we just spoke about, the Hill RBF3, the Barrett's, Haigis, and the Holiday 2, should provide the highest accuracy. But you have to always look at them with a very keen eye, and then you won't make much mistakes. Thank you.
Thank you, Dr. Gaurav, for that excellent talk. If there are any questions, we can take them. Meanwhile, what is your choice of formula for post-RK eyes? Because this is something which I think a lot of us face difficulty, and we have refractive surprises. These patients also are demanding, they have undergone refractive surgery. So do you have any
I do a lot of post-RK eyes, and the biggest challenge is they're really flat. Sometimes, the keratometry is like 23, 24. Now my lens star doesn't measure flatter than 30, and if you try to use the T-cone, you again don't go beyond like 27 or 28. So what I now rely, because the problem lies with accurate K measurements rather than with the formulas which you might want to use. And then I use the Ascaris calculator fed in the OCT based data, the Pentacam based data. These are the two which will fit into it. Other things will not even go into the formula because it doesn't take lower than 30 Ks and all. So then we've kind of worked around a way and found that to work well for us in these post-RKIs, and then still err on the side of using the highest power lens available and then add another one to it. And then so you might just hit jackpot.
Have some amount of residual myopia.
Because absolutely. So that's what has worked. And I also have done quite a few torics now with our post-RKIs, which initially I used to totally avoid, but seems to be working really well again using the pentacam. If it has different optical zones are showing consistency in the axis and the magnitude of astigmatism, you can still go for it and looking at the maps and trying to pick up those cases where it will work. So it has been very gratifying for some of my patients.
What I like to do for post-RK in cases now is to use ray tracing.
Ray tracing,
because
yes.
that accurately measures all the optical elements, and then by ray tracing you're able to kind of
that's what I actually spoke about.
Still I kind of want to target about 1.5 diopters of myopia, and you end up with.
Are you using the Oculix and feeding data from few of these
CSO.
machines?
CSO
okay, on the
MS39.
CSO. Yes, that's MS39 is the one, is it?
Yeah, MS39.
That has the ray tracing built into it. It would be great to have it built into your device. Otherwise, kind of putting it into another system and gathering all the data is so tedious.